All right, hi everybody. I think we'll get started. My name is Robert Hughes. This is Lauren McCafferty to my right. She's our rising chief resident, and this is Eric Reed, our MD candidate from Case Western Medical School. We're from University Hospitals Cleveland Medical Center, and we're going to talk to you guys about the EMIG and bringing it back to the basics, incorporating the basic sciences into your EMIG experience to create a more meaningful experience overall for the people who are interested. And so with that, do we have a clicker? We don't even need one. I'm going to introduce Dr. McCafferty, who's going to talk about our objectives for the day.
All right, so one of our objectives is to discuss the importance of the EMIG as a source of engagement for students as aspiring residents, residents as aspiring teachers, and then linking the strong bond between the residency and the medical students. Another objective is to identify the benefits of linking the basic sciences back to the clinical skills for the preclinical medical student, and then also to discuss the mutual benefit experienced by participants in a multi-layered educational program from both the student, the resident, and the faculty perspective.
So just to survey the audience here, who are residents? Raise your hands for me. Awesome. And who are medical students? All right, cool. I'm glad we have some. And who are our attendings? I got plants over here in the audience with some of my colleagues.
So those involved in your EMIG, what's your experience been? Just off the top of your head.
You guys show up and there are suture setups and maybe there is an intubating mannequin and you guys just perform the procedural competency and then kind of bounce out.
Was there ever a lecture or, very brief, was it on the procedure itself or was it on, yeah.
And so that's what, yes, in the back.
One of the things I've covered with the group that the institution was previously was the things they don't teach you in medical school, like one of the sessions that, sorry, my name is Gary Gaddis. I'm at I'm at Washington University. I used to be at UMKC. And I would talk to the EMIG about twice a year, but they like to hear things that they didn't hear in medical school otherwise, like issues about contracts and you know, thinking ahead to your first job, what to watch for, but it has nothing to do with your presentation.
No, that's actually excellent. So the EMIG traditionally is structured as a series of exposures, right? Exposures to the field so that people can become interested in emergency medicine early on and understand what they're getting themselves into. So it ranges from lectures, skill stations, like we're going to kind of lead into a little bit more, but just general exposure to the field like that. Talk about contract, talk about the job, life in the day of an emergency medicine physician.
Shadowing opportunities. Yeah.
And so the EMIG serves as a source of engagement for people, right? It teaches medical students to become future residents and gives them exposure to the field. It takes our residents and puts them in a teaching capacity and exposes them to the benefits of teaching. It develops a strong educational bond between your medical school and your residency program, which is so key. And so how can we make this better? So traditionally, education in medical school is life on an island, right? We sit there as medical students and we sit in lecture and we learn the basic sciences, and we don't yet have a clinical context or a clinical relevance for how that factors into what we're going to do in our future. Then we become residents and it becomes procedural competencies at the bedside. How can I suture better, be more efficient at it? How can I intubate this patient well? When do I recognize a difficult airway? And then as an attending, you have more of an overarching understanding of all of this in the practice of general emergency medicine, plus things like operational design, flow goals, etc. in your department. And it becomes this linear progression of aspiration. You are a medical student learning from residents procedural mechanics. You're an attending teaching residents procedural competencies. And so you're bucketed into these relationships, attending to resident, resident to medical student to their preclinical years. But it's missing something. It's missing connections. If you go back here, you're noticing that it's this linear progression and we just jump islands, right? We move from our experiences as medical students, we leave the preclinical years behind after we take the USMLE, and then we hop into the actual experience of practicing in a hospital. But there's a better way to do this, I think. So what if this was our educational paradigm? What if this is what the EMIG became? What if it was a grouping of the attending, the resident, the medical student, all coming together to increase the educational yield for everybody involved, to combine into context, meaning, and growth for everybody. And instead of a linear progression, it was more buckets. What if instead of islands, we built bridges between those islands. So it wasn't just a linear progression. It became something where it was mutually beneficial, where the medical student was teaching the attending was teaching the resident was teaching the attending, and there was this back and forth where everybody who showed up got benefit. And you guys might ask yourself, exactly how are we going to do that? How are we going to turn this? This is gross, right? For everybody who has been doing this for a while, this is terrible. How do we turn this right here into this? Because it's not that one-to-one leap. It's not just going from understanding what you're doing and understanding this in the preclinical context and then magically becoming good at suturing. There is something in between that to understand how things operate. So to give you a really good idea of exactly what that means, I'm going to introduce Eric Reed, MD candidate from Case Western Reserve University, and he's going to talk to you guys about his experience.
Yeah, so building off those last couple of slides, I learned wound healing from a histology lecture in a dark lecture hall, a series of pink and purple slides, and each slide looked exactly the same as the next. I memorized the images on the slides, regurgitated them on the test, passed the test, and forgot all of it. Then I went to the first emergency medicine interest group lecture of the year, and it was on suturing. It was on wound healing. The slides are up there, actually. And looking at that, I saw a connection that I hadn't seen before. I saw the minute cellular detail expanded into clinical relevance. The myofibroblasts were no longer pink smudges on a slide. They were the reason that a wound contracted and the reason I needed to evert the edges when suturing. And I took this forward through the rest of the first year of medical school, through second year, as a motivation to learn the basic sciences. I could see the relevance, and I had reason to stay up late studying because I knew that it would be useful. Recently, I studied for Step 1, and this information, along with the other workshops we held through the first 2 years, provided the anchor, the foundation around which to build this academic study. When I was going through the stages of inflammation, I could separate it from everything else because I had a picture in my mind of where it would be useful. And so I know that there are students in my class who can sit down and memorize a deck of 500 or 1,000 flashcards as they are, but I know that there are just as many who are like me, who need that anchor to build their understanding around. So I believe that these skills anchor the basic sciences as much as the basic sciences inform the procedures.
And so Dr. Reed, future Dr. Reed is hitting on the exact crux of what we have done. So we have taken a lecture series before we teach the skills station, and we put it into the context of what people are learning at that moment. So what we do is we coordinate with our EMIG president and we say, what are you guys learning at this time? What is your clinical block? Okay, it's wound healing. It's early on, it's histopathology. This is a perfect time to teach you about the skill of suturing for exactly this purpose. We cover the basics, we put it into the clinical context of what they're learning at that moment, and we bring it into the real world of clinical practice, and we say, okay, now let's put this to use. And so what we're finding is that people are enjoying their experience, and instead of that shock and awe exposure of, oh my God, I can't believe I'm suturing, or oh my God, I can't believe I'm intubating, it's putting it into a real world application for what they understand at that moment. And it becomes mutually beneficial, not just for our medical students, but also for our residents. So Dr. McCafferty is going to tell you about her experience and exposure.
So kind of when, kind of alluding to what Eric said, when you're a medical student, the focus is primarily on learning the basic sciences, and then procedures are kind of just a secondary thing. You know, you come to workshops that are, pretty much on your own time and learn these procedures. And then kind of the opposite becomes true when you become a resident. The focus kind of shifts toward, focusing just on how to become a clinician and how to master the mechanics of a procedure. So how do you go through the steps of performing RSI and placing a central line, placing a chest tube? And it's all about numbers, really. How many lines can you put in? How many tubes can you get before you graduate residency to the point that you, develop enough muscle memory and feel comfortable enough doing the procedure that you can call yourself competent. But what we realized, in kind of coming up with this program that we've developed is that there is a huge disparity between the preclinical years and the clinical years. And so we developed what's called the Emergency Medicine Immersion Series, where, kind of as Bobby was describing before, we host these workshops like a lot of EMIGs, I believe, do, but kind of to make it a little unique, we incorporate the basic sciences. So prior to each workshop, we have about a 10 to 15 minute lecture where we revisit the basic sciences and go over, and we tie it back to the histology, tie it back to the anatomy and the pathology, physiology, and that kind of, we hope to create a more, like a better, more comprehensive learning experience for the medical students. And what started off as being something that we thought would just, benefit the medical students and not felt like an obligation, but, kind of along those lines, we quickly realized that it was just as beneficial, if not more so, from the resident perspective. For me personally, I believe that, by having to teach the medical students the finer points of the mechanics of intubating someone and, talking about airway anatomy and respiratory physiology, I've personally felt like that has made me a better clinician as a whole. I've not just become better at doing the procedure, from a mechanical standpoint, but I can also, I'm better at anticipating the complications, understanding why we do something, not just how to do something. And it also has helped me realize, not, when you should do a procedure, but also when maybe you shouldn't do a procedure. And I think that's kind of hard because especially as emergency physicians, we're very procedure hungry, and I'm very guilty of that myself. But I think understanding, what's going on, from an anatomical, physiological standpoint, to support those procedures, that's made a big difference, at least for me as a resident.
And you know what it does too is, I remember when I was a resident, I went to these EMIG events and I taught them half out of guilt and half out of obligation, feeling like I wanted to give back and I wanted to introduce our medical students to these procedures and say, this is what we're doing, this is super cool. I remember when I was a medical student years ago, we intubated pig lungs, which was kind of cool. Got to see the lungs inflate, deflate. And just to wheel it back to the shock and awe aspect of it, I was so engrossed with what I was actually doing that I wasn't taking the time to appreciate the basic sciences that were so integrally linked to what I was doing, to understand the pulmonary physiology. And nobody was teaching me that component of it. They were teaching me to intubate, teaching me to crike. They were teaching me the hand mechanics. Hand goes this way, hold the tube in your right hand. This is how you kind of position the head. And so what we have found is that resident engagement has increased because instead of being something that's more of an obligation or feeling like you just need to kind of put yourself out there to assist with your fellow colleagues who may have an interest in medical student education, it's become this mutually beneficial relationship where our residents are learning and experiencing from a unique aspect as opposed to just teaching and handing down procedural knowledge and competencies, which has been hugely beneficial. So, anybody have any questions so far? Yes?
So your events so far have all been rooted around procedures. Are there also non-procedural sessions that you do, like you're talking about chest pain, and it may not be a procedure per se, but it's still kind of integrating the clinical assessment of chest pain with the basic sciences that they're learning?
So most of our workshops are centered around a procedure because I think that's what attracts the preclinical students. But one of the workshops that we did last year was trauma assessment. So we went through like primary and secondary surveys, and we just kind of talked about, what kind of injuries are you looking for, and so it's a little bit less of a procedure, but that, and I felt like that got great response from the students. But I think it's hard to to say, hey, let's come talk about chest pain and get a good audience. But whenever we advertise a procedure, I think that immediately captures their attention.
But the great thing about the EMIG is that it's so dynamic, and you bring up a really good point, and to the gentleman's point in the back, is that there's so many facets of the educational components that go along with an EMIG, and it's fun to sit people down and do thought processes, and this is how you navigate a chief complaint and how you build a differential, because there's so much utility in doing that. And I think actually that the basic sciences play a big role in that, and so one of the things we like to do, some of my colleagues, we sit down, just last year we sat down and mapped out, this is where we were successful in the year prior doing this, and this is where we would like to take it in the future. So research is another great one. How do I get involved in research? What do I do? And we find that we have different levels of interest amongst different people depending on where they want to take their career. But again, to the crux of what an EMIG is, it's exposure to all of these facets of emergency medicine and really finding what your true interest is. So just to bring it all together, we talked about life on an island, but it's not just life on an island, right? It's a journey. It's island hopping. We go from medical student to resident to attending. We achieve these underpinnings of the basic sciences so that we understand what we're doing in the clinical context when we become a resident, so that we achieve a basic clinical competency, so that we could do the intubation, so that we could successfully place a chest tube, so that we could get good cosmesis with a wound repair. But we need to build those bridges, and I think that's where we've had the best success with what we've done, is by mirroring our clinical exposure to our medical school and what they are doing at the time with their learning paradigms. So this is the way medical education is going, period. Back in the day, we did 2 years of basic sciences, 2 years of clinical work, and then residency. But it is not that anymore. We're finding more and more integration of the clinical skill set and patient exposure into the earlier years in medical school, and we've all found benefit to that. We haven't found that it has bled into the EMIG that much. We still sever those relationships, but we shouldn't, because that's where the true beneficial bilateral learning happens, where the resident is learning from the medical student, the attending is learning from the resident, where we all have this nice symbiotic relationship with the educational paradigms that we're trying to teach. So instead of me just handing something down to Dr. McCafferty and Dr. McCafferty handing something down unilaterally to future Dr. Reed, we have a mutual benefit. And that's why I thought that the presentation was going to benefit from having all 3 levels of us present instead of me just talking to you guys, because this is what it's about. You don't build a bridge from one side. You need to build it from both sides. And so when we think about building those bridges between the levels of education, you need people bringing something to the table from both sides of it in order to be successful with it. Any questions? Yes, sir.
So the role of the faculty member is kind of more here in the background, letting the residents and students kind of drive the shift. Is that?
Yeah, so what we have found a lot of success with, and Dr. McCafferty has taken great charge with leading this, is I help coordinate kind of the overarching schedule for the course of the year, and then I am present at a vast majority of these, and we have other faculty members that join us. But we found a greatly increased resident presence at these teaching sessions, again, because of this mutually beneficial teaching paradigm. And there's a lot of learning that happens. Having that exposure to the basic sciences is really valuable for me, because I purposefully forgot a vast majority of that stuff. ESN is something that I never want to hear again, but I do remember the H&E stains, and it's kind of a blast from the past, and it kind of bubbles back up. And then you remember why you're doing what you're doing. So I think about it clinically. I'll be sitting there in the department doing a suture repair, and I'm like, wow, you know, yeah, I get why I'm doing this, and I kind of bring it back to that sort of wide-eyed wanderlust that we all have when we start medical school, when all of this is still magical. And it's kind of made it a more, I feel better when I practice. Yes, sir?
Great presentation, team. And I think my first question is to ask you, having developed, you know, you're going to be doing all the different procedures and all that, and mastering this concept, and also that's actually a great way of having the medical student get involved in emergency medicine, you really get interested in all that hands-on as well. What is your next step after this?
It's a really good question. So to expand this, like we had kind of talked about earlier, to incorporate more kind of lecture-y type stuff. I think the chest pain thing is a really, really good example of how do you teach medical students to develop a broad differential diagnosis. And the great thing about this process is it's been an evolution. And I think just in keeping with the theme, this isn't a unilateral edict when I say this is what we're going to learn. This is surveying our medical students and saying after every year, we have Excel spreadsheets, we have physical data to say this is what people enjoyed. We survey at the beginning of the year. We try and take the academic calendar and cross-correlate with what's happening at that moment so that we make sure that whatever procedure clinics we are doing kind of hit on that. But I think future state is incorporating more events that may not be as procedurally geared, but that expose people to the true crux of emergency medicine, which is clinical practice at the bedside.
So may I suggest, as a sort of going back to a slide before, if you may.
Of course.
Is that you, another slide, I'm sorry, is that you have a triangle right now, right? What's missing there, of course, logistic as well, is what we do in OSCEs, right? Mm-hmm. The patient. If you can even get the patient involved in this model, I think that would be extremely beneficial to everybody.
It's a really good idea, actually. Yeah. Awesome. Well, thank you all very much. Appreciate it.